audience, welcome to this session. Now it's my great privilege to introduce you our speaker from Japan, Dr. Ando, a specialist on orofacial pain and oral medicine. Dr. Ando has completed his training through the residency program at the Orofacial Pain and Oral Medicine Center at the University of South California, Herman School of Dentistry. Currently, he is a visiting associate professor of School of Dentistry, Showa University. His topic today is burning nose syndrome, bridging what we can see and cannot be seen. Let's welcome Dr. Ando.
Thank you very much, Dr. Lin, and I'd like to thank the organizing committee for hosting such a wonderful event. It must have been really hard to organize this international conference under such circumstances. So after 2 years of postponement, delay, I'm very happy to finally be here and be able to present to you all about this topic. Today I would like to talk to you about burning mouth syndrome in front of all the brightest minds from across the world. We said 25, 27 countries representatives. So pathologists, I know you all are very diligent and research and diagnosis. It's just great to be here. It's my great honor, and I'm really happy to be here for presentation. A little bit about myself. Again, my name is Akihiro Ando. The reason why I want to talk about myself first because I'm not one of those big shots. Just listen to the name and you know who you are. I am an orofacial pain and oral medicine specialist. I got my training in University of Southern California, Orofacial Pain and Oral Medicine program, back in 2011 to 2013. After becoming the diplomate of American Board of Orofacial Pain, I went back to Japan and opened up my own practice, specialized in orofacial pain and oral medicine. So I hadn't held a handpiece for a long time. Maybe that goes to say to a lot of you. I don't do general dentistry, just seeing orofacial pain, oral medicine patients. This is the disclosure. I have no conflict of interest. As maybe all of you know, oral medicine, orofacial pain, it's really hard to get some company to fund you. So, there's nothing much to disclose here. This is my clinic located in Tokyo, Japan. A very tiny clinic, just a waiting room and one room for medical consultation, examination room, and second floor is for lectures. But this clinic here is a unique clinic because this is the only clinic, only one clinic which only see orofacial pain and oral medicine patients and no general dentistry. I said orofacial pain and oral medicine, but in fact, most of the patients I see here is orofacial pain patients. Because after I went back to Japan, I figured that a lot of oral medicine patients just go see an oral surgeon in Japan and get a decent treatment there. So as long as the patient is happy, I am happy too. But for orofacial pain, it's a different story because unfortunately, it is very hard to find a decent, well-structured, organized training program for orofacial pain specialists in Japan. That's why I had to go abroad and seek for a training program. Inside of here, there is a consultation room, examination room. This is where the patient spent about 70% of their time. Initial consultation in my clinic is about 60 minutes. And 70% of the time, I will sit with them and ask them what their problem is and try to figure out the characteristic, the quality, and what kind of pain the patient is experiencing. Because after all, you just can't see pain. You can't measure pain. You can't see the pain objectively. That's why you have to learn a little single bit of the character of the patient's pain. After consultation, there is a small chair for examination. This is where I do my head and neck exam. Of course, for oral medicine, I sometimes do a incisional or excisional biopsy. So there is a little unit I can use a hand speed for, maybe like intrabony biopsies. But I rarely use that. It's just a chair that goes up and then recline back and then recline back up. I like oral medicine because it's straightforward. It is challenging, but it's straightforward. These are the cases I had when I was a resident at USC, but let's see, like angular cheilitis with skin involvement, papilloma, herpes labialis, mucosal fibroma, verrucous, or squamous cell carcinoma. So these lesions, it's there when you see it. No one can miss that as long as you are trained to find it. And if you don't know what it is, then of course you can have the colleagues to come in and take a look at the lesion together and come up with a differential diagnosis and figure out what it is. But pain, you actually can't do that because you bring your colleague to the same room and ask them to see the patient. What you and your colleague will see is a normal mucosa or normal radiographs or normal MRI imaging studies, things like that. So pain is very challenging condition to actually diagnose and then treat. And of course, that is the reason why it is very hard, challenging to run a well-structured research too. It's hard to get data because the pain is subjective, right? But here, I am in front of oral pathologists, and I think you all know. You've been there, you've done that, you've heard that, you've learned that. There is a special thing for the oral pathologist can do, right? Get a specimen, burning mouth, get a specimen from the tongue, and do the peripheral abnormally injured neuron stain. Like you do that, and if you can picture pain like this, PAIN stain, peripheral abnormally injured neuron stain. Now, if you can do that, how wonderful it will be. That's like a dream come true for all the pain specialists, not just orofacial pain, but just pain in general. But again, you all know this is not true, right? There is no objective measure that you can use clinically at this point to visualize or quantify the amount of pain the patient is experiencing. Today, I would like to talk about burning mouth syndrome, but first I would like to open up with pain in general. And after that, I will go into what is burning mouth syndrome, and then can we actually treat them. And finally, I'd like to touch on the possible objective measures, maybe even histologically, that you may be able to perform on these patients reporting pain, which you can't see clinically, but if you get a specimen from there, you may be able to see it. And I would like more research done on that because the current research on the number of patients and number is very low, like 20s, 50s. I rarely see any patient with research done over 3 digits. So it's still narrow, it's still small. That's why I would like to present to you today in front of oral pathologists, and hopefully somebody will come up with the pain stain. So pain in general. I always like to open up the presentation, my lecture with, doctor, what do you see? I got this from a kid's picture book. I used to read this book called Brown Bear, What Do You See? To my kids when they were 2 or 3. It goes like, Brown Bear, what do you see? I see a red bird looking at me. Red bird, what do you see? I see a yellow dog looking at me. And it just, excuse me. And it just goes on, but doctors, what do you see? Oral pathologists, oral medicine specialists, when you see a patient, you may see a lesion. General dentists, when a patient comes into your clinic, the most common chief complaint they may complain is, hey, doc, when I eat, my pain hurts. When you examine the patient, it probably isn't so hard to find the cause of pain. Like, there's a cavity, your gum is swollen, take a radiograph, and then you will find a radiolucency, things like that. But I would like you all to have in mind that what you actually are seeing is not the pain itself. Because I like to repeat this over and over and over and over, but even with the most advanced science technology, diagnostic technology, you can't quantify pain yet. Maybe on a research purpose, you can use like functional MRI to see which part of your brain is hot and then which part is not. But clinically, when you sit in front of the patient and patient reports pain, there is no instrument go beep, okay, your pain is 30 out of 100. And beep, 80 out of 100. Oh my gosh, you're in a lot of pain. And let me take a look at you immediately, or go beep, 0 out of 10. Liar, get out of my clinic. You can't do that. When a patient is reporting pain, all the doctors, all they can do is say, okay, you say you're in pain. Let's see what is causing pain. The lesion you are seeing is only a possible change in your body that may be causing pain. So you're not looking at the pain itself. Sometimes you cannot see any changes in your body visually, but there could be something causing the pain. There, I would like to touch about that in the 3 types of pain I'm going to categorize. But again, all you know, whatever you see in radiographs or clinically, whatever you see is just secondary. It's not the pain itself. Pain is subjective. So it is very hard to share with others. All the sensory experience is extremely difficult to explain to others. That's why patients have hard time explaining about pain. Doctors have extremely difficult time understanding patients' pain. Who in here has an AirPod, like AirPod Pro, with like a noise canceling? Any noise canceling? Noise canceling headphones, like Bose Quiet Comfort, Beats, AirPod, something like that. No? Okay. There are some hands. Yes, thank you. Can you describe to your friends or colleagues how much noise canceling it does? How much difference it makes to your experience that you enjoy music? Can you? I mean, I bought AirPod recently and I did use it on the airplane on the way here, but it was amazing. Without the sound, without any noise of the airplane, I could concentrate on the music. So it was amazing. But if I were to quantify the amount of cancellation of the noise and share it with my friend and have that friend agree to me, that is impossible. Your friend may be like, maybe like 20%. If you have your other friend try it, then maybe like 70%, and your other friend may be like 0%. But it is nearly impossible to have everyone agree on how much noise canceling it can do, this product can bring to you. And it goes the same for pain. Because all sensory inputs from our sensory neurons, it is transmitted finally to the brain and interpreted in brain. What it does is, before it interprets, it modifies. Sometimes it is amplified, sometimes it is suppressed. So it depends on your previous experience, or if you are expecting the painful experience, then you may feel more pain. If you are really tired and depressed, then you may feel more pain. even with the exact same stimulation, the amount of pain the patient may experience within a day, it can change. And it can also change if you give the same stimulation to a different person. So that is why it is extremely hard to conduct a well-organized research. There is a quantitative sensory testing. That's probably the best thing we can do to try to find the abnormality of the function of the nervous system, but there still isn't a good measure. Pain. A lot of patients tell me that when they are focused on something, they feel less pain. So sometimes a patient's brain can suppress the pain too. So might as well just ask the patient to ignore the pain all the time. You think you can do that? No, that's impossible. I mean, would you tell your patient experiencing a severe migraine, my head is pounding, I have to take a day off work, and do you think you can tell them to ignore the pain and go to work? That's impossible. Even with the mild pain is like, for example, having someone you don't like in the same room, I think. Your worst, it doesn't have to be your spouse or wife or a husband, but I am happily married. I have to say this, because otherwise my wife will kill me. But if you have your worst enemy in your same room, imagine, you hate this person very much and he's in the same room. Even if that person is standing way far away from you, you know he's there. I mean, it is unpleasant, it bothers you, and once that person approaches you, then your pain is going to get worse and worse, and finally when they start talking and start arguing, it is a nightmare. Pain is something, when it's there, you can't ignore. Many patients tell me that if I'm focusing on something else, I feel less pain. But if I start to think about pain, yes, I know it's there. So you can't ignore pain. Pain by definition is unpleasant. IASP, International Academy for Study of Pain, defines the pain. Pain is an unpleasant sensory and emotional experience associated with potential tissue damage or resembling that of potential tissue damage. So it is unpleasant by definition. So if you enjoy pain, some people, I don't know if they do, but that's not pain by definition. I like to categorize pain. There are many ways to categorize pain: acute, chronic, or by duration, by quality, like sharp shooting pain or cold stimulation pain. A lot of ways to categorize pain, but I like to use this three categories. One is somatic, the other is neuropathic, and the other is psychological. Actually, I did a TED Talk back in 2016-17 about 3 types of pain. So if you Google TED.com and type in my name, Akihiro Ando, I think that presentation is still available on TED website. So if you're interested, please have a look. But somatic pain is the pain that all of us have. It's called physiological pain. It's the pain that is there to let you know you are in danger, like you're infected or you're touching a hot oven. If you can't realize or recognize, then you're in deep trouble. But the reason why you can stay away from danger is because there is somatic pain. And trust me, I know very much about somatic pain. I am an amateur boxer. I'm on the left side. That's a photo from the match I won, but on the match I lose. Sometimes you try to punch someone, they can punch you back, and when I lose, I look like this. It really hurts. My nose was bleeding, and it hurt for like a week, but after a week, it gets better. The somatic pain, when the danger goes away and your tissue heals, is it healed? I don't know. If my nose is kind of crooked, it's probably from that fight. Somatic pain is a physiological pain, and when it's treated properly, then it should go away. But psychological pain is another pain that people can feel, and it is called a pathological pain because it is not there to protect you from danger, but it is pain that you feel from your mental problems. But it doesn't have to be severe depression or severe anxiety to feel pain or feel any symptom from your mental condition. Because let's say it's right in front of the presentation before all the audience, and you get very nervous. With that nervousness, your heart beats faster, tachycardia, and you may have to go to the restroom very often, and so you're breathing shallow. There are certain changes that can actually present to your body from the change of your mental status. And sometimes it can present as pain, as somatoform disorder. It doesn't have to be that severe. Because of COVID, I didn't have to travel a lot to other countries. For 2-3 years, I got to spend a lot of time with my kids. And this picture was taken about 12 years ago, 10 years ago. My daughter was maybe 6-7 months old, trying to read Nagel's Oral and Maxillofacial Pathology. That's the book I used to read when I was a resident. But before I come here, it said I can't be with you for about a week, and she almost cried, and that almost made me cry, and it was very painful to leave the family. So psychological pain, it doesn't have to be something physical happening to you, but it can be painful. So what about neuropathic pain? In the past, burning mouth syndrome had been thought that it arises from all the mental problems. But now we see many evidence that it probably is not. Or not all of the burning mouth syndrome patients are originating from the psychological pain, but from neuropathic pain. Burning mouth syndrome is neuropathic. Now we have more evidence about burning mouth syndrome being neuropathic. Neuropathic pain is a type of pain that you can feel from a dysfunction of your sensory nervous system. So normally your body temperature shouldn't be hot, but when there is a dysfunction of somatosensory system, it can create a action potential from the peripheral nerve sending a signal to the brain saying, oh, my tongue is hot. Sometimes it can happen from injury. Traumatic injury can cause neuropathic pain. It can damage nerve physically. Normally it should heal over time, but sometimes the healing is inappropriate. Then it will cause a dysfunction. Just like, from outside it looks normal, but let's say the light is almost, turning off and it starts to flicker. That's pretty much similar to a dysfunction in nerve. It starts to flicker without, a reasonable stimulation. That's why you can have a tingling, burning, disturbing sensation inside of your mouth. Because I think oral pathologists here have never, I wouldn't say never, but you don't really see orofacial pain patients frequently. I brought one video of me seeing a patient in my clinic. This patient is a 45-year-old female, first visit, came to our clinic complaining about burning sensation of her tongue. And she's had this pain for over a year, a little over a year, and she's been to other doctors and they said nothing was wrong. But she still had pain. It scares the heck out of the patient when there is nothing nothing wrong with your body, but you still have symptoms, they start to think, oh my gosh, it's something, must be something serious. It could be cancer, it might be life-threatening disease hitting in my body and causing this pain. But burning mouth syndrome, that's actually quite benign. If you explain what is causing the pain and what you can do, some patients even say, okay, maybe I don't need a treatment then. I'll just bear with the pain and go on with my life. Okay, so that was my patient. So she has been reporting that her pain is always there. If you rate it from 0 to 10, NRS, numerical rating scale, sometimes you use visual analog scale. She said it's 5 to 7 out of 10. So it's quite significant. And some people will tell you like 12 out of 10. And at that time I may be like, okay, there might be something psychological going on. But still, it's the second best way to measure pain at this point clinically. So her head and neck examination, unremarkable. Intraoral, unremarkable. She was reporting more pain on the left lateral, so I took a photo of it, but it doesn't look very suspicious. Her dorsal, it doesn't look very suspicious, just a little white, but it's better than being flat and red, suggestive of anemia. If there's not like thick coating, suggestive of candidiasis. So, what can you do for the patient? Going on, her systemic condition, unremarkable too. She's 45. She's taking statin for her cholesterol, and who doesn't at the age of like 40s, 50s, right? But other than that, she has asthma, so she has steroid/beta blocker, and also she was taking some medication for constipation. That was pretty much it. And one interesting fact she reported to me was that she has consulted a psychiatrist because her dentist told her that he can refer you to a dental hospital. But even if you go to like a general hospital and go to oral surgery, what they will do is they will probably give you like anti-anxiety medication and things like that. So she found a psychiatrist near her place, near where she lived, and she consulted. A psychiatrist prescribed her 2 types of benzodiazepines for her anxiety. And she's been taking for like 6 months, but she said it's not helping with the pain. So what is going on? We still don't know. There are a lot of theories involved in burning mouth syndrome, but starting with the treatment, because I showed you the patient, I think you might be wondering, what happened after that. I put her on topical clonazepam. Topical clonazepam is one of the treatment method that is also put on a Cochrane review article as having a very low quality of evidence, but it's still there, better than 0. And before that, I'd like to mention she was not taking RCA nuts, areca nuts. And Dr. He might not be here in this room right now, but in Japan, we don't have betel quiz, areca nuts, so it's not in my general questions that I ask to my patients, but I do have the patient go through a course of antifungal. In Japan, miconazole is very easy to get and use in a form of a gel. So I use that for this patient, but for 5 days. Because candidiasis, sometimes you take a swab and you can't detect it. Sometimes if you put the patient on antifungal and it resolves, or it gets better. So if it doesn't hurt the patient, why not, right? Because burning mouth syndrome, to treat it, it may take a little time, but antifungal medication is quite easy. I saw even a poster presentation saying that they tried antifungal medication on patients reporting burning mouth syndrome, and many of the patients' pain went away. So I think it is a reasonable screening process to make sure you are not missing out on anything. I will talk about a differential diagnosis in a few moments, but this is the literature I am referring to, topical clonazepam and somatodynia, a randomized placebo-controlled study back in 2004, and it has been repeated in many other studies, and this is one of the original. For the treatment of burning mouth syndrome, because the data is very sparse and number of N is very low, the quality of evidence you can find on the literature is very limited. It's very low quality of evidence to benefit. But one of them is topical benzocaine, topical anticonvulsants, electromagnetic radiation, and physical barriers. Of those four, I commonly use topical benzocaine and sometimes anticonvulsants. But anticonvulsants, there are many types, but gabapentinoid, so gabapentin, pregabalin, margabalin, those are a common, easy to get, easy to use medicine for possible neuropathic in origin burning mouth syndrome. If the patient doesn't respond with topical benzocaine, I often add anticonvulsants, any gabapentin, pregabalin, and sometimes even antidepressants, tricyclic acid. Tricyclic antidepressants, or TCAs. Amitriptyline, nortriptylines, because this medicine has been there for a long time, and for a long time, they didn't have gabapentinoids. It came out within 20, 30 years, maybe even more recent. So a lot of people went through a course of antidepressants, and there are many data out there, but unfortunately, many of the poorly designed studies are included in these studies. So that's why there is this is effective, this is not, and this and that. Data is very sparse, so that's why it is an insufficient or contradictory evidence. But about the treatment, I don't want to go into much detail because there is very limited time, and I want to also talk about the histology of it too. The patient demographic, a common patient demographic is female, more commonly seen in female, 7-to-1 ratio. It's very rare to see burning mouth syndrome in a patient younger than 30 years old. If you have a patient come in, young patient reporting pain, think of something else, like, candidiasis or anemia or some psychological issues. Prevalence, 0.7% up to 3.7. If you include many studies, the number can go up to 15%, but that's kind of absurd. So about 1% up to 3.7, that is a feasible number, I'd say. Maybe, one person in this room can have a burning sensation of your mouth. It's a quite good number because, maybe you don't experience many burning mouth syndrome patients, but subclinically, or they might have something in mind that is bothering you, but not sharing with you. 63%, about 2/3 of patients experience xerostomia, dryness of your mouth. It doesn't have to be hyposalivation, just a feeling, because sometimes it is only derived from a sensory changes of your oral cavity. Just like the person you just saw, she was reporting a dryness of her mouth. She said it feels dry from the past, but it has significantly gotten worse when the symptoms started, so that is one form of xerostomia. Bitter, metallic taste, or dysgeusia, the abnormality in taste, the patient didn't have, but up to 6 and 10, 3 and 5, patient can report kind of weirdness in their taste sensation. We know what these population, what these patients are, but we just can't really visualize what is causing this pain. Differential diagnosis, there is the term primary burning mouth syndrome, secondary burning mouth syndrome. I just hate the term secondary because, it's a different disease, it's a different diagnosis, and it shouldn't be called burning mouth syndrome when it's not. Like iron deficiency anemia, when you lack vitamin B12, folic acid, pernicious anemia. It can be from other minerals or candidiasis. Sometimes lichenoid reactions, lichen planus, those type of conditions can also mimic burning, can cause burning sensation of your oral mucosa. But again, if you examine carefully, then you will be able to find abnormalities in the lab findings or clinical findings. So it is critical to differentiate these conditions before jumping into a diagnosis of burning mouth syndrome. Because the diagnostic criteria of burning mouth syndrome is very vague. There is a diagnostic criteria in ICHD, International Classification of Headache Disorder. This is like a classification you must refer to when you are diagnosing headaches, migraine, tension type, cluster. Orofacial pain specialists in the US treats headaches too. So that's why I got trainings in headaches too. But here you will also find burning mouth syndrome in here, like trigeminal neuralgia is included. So all the pain from neck and above is in this paper. And I'd like you to take a look if you have time. It's quite interesting, especially when you have headache, try to see what it is by yourself. 13.11, burning mouth syndrome. It's an oral pain fulfilling criteria B and C. And I don't even know what A is there for, and I don't know what D is for because if it's something fulfills B and C, I don't really see the significance of D, but it's still there. So recurring daily for more than 2 hours a day for more than 3 months. So it must be chronic in nature. And pain has both the following characteristics: burning quality and felt superficially in the oral mucosa. Oral mucosa is of normal appearance and clinical examination, including sensory testing, is normal. Now, here it says including sensory testing is normal. This is going to change because there's another newer criteria, which is called IAOP, International Classification of Orofacial Pain. The previous criteria was for general physicians, doctors, because there are a lot of pain that can happen from neck and above, and they list the name and then criteria on there. But this criteria is published in 2020. The first edition, IAOP, orofacial pain specialists got together and categorized all the types of pain, including pulpitis, gingivitis, trauma, TMD, and things like that. And included in here is also burning mouth syndrome. Actually, what you see here in A, B, and C are just identical to ICHD. The IAOP is made over the base of ICHD because in the future they hope to combine these diagnostic criteria and have all the diagnostic criteria from the neck and above, including oral cavity. So I think it's quite interesting. But here in D, what they changed is oral mucosa is of normal appearance and local or systemic causes have been excluded. It doesn't include a sensory testing is normal because in many cases, if you do a quantitative sensory testing, you can find an abnormality. Like thermal testing, you raise the temperature slowly and then to see where the detecting threshold for the heat, cold, vibration, touch. You can use like pinprick, you can use like a little fork to see the spatial recognition. So, there are many sensory testing you can do, but, I don't want to go into much details here. Clinically, it is very time-consuming and money. It costs money to, buy the test for quantitative sensory testing. So, clinically, it's probably not going to be feasible, but here for research purpose, maybe. And there are a lot of doctors working to come up with research diagnostic criteria of burning mouth syndrome. There are doctors from Japan involved, from UK, King's College, Dr. Yilmaz, Dr. Renton, I believe, and there are many doctors from US, other parts of the world too. So hopefully those diagnostic criteria is going to spread to the world and be able to gather data so that we can combine them all to find a better understanding of what burning mouth syndrome really is. Because the spectrum of the symptoms is very, very wide. Sometimes, I doubt if this patient is even, neuropathic in origin. Sometimes it can be like psychological. And on the other hand, there is a there is a neuropathic type of pain. So, these diagnostic criteria is very vague. And is that it? Can we even call that a diagnosis? Well, yes, you can, because you know how neurologists diagnose primary headaches? Like migraine without OR. See, ICHE, it looks very similar. There is no need for like specific clinical finding that needs to be included, like at least 5 attacks fulfilling criteria B and D, headaches lasting for 4 to 72 hours, and unilateral pulsating, moderate or severe intensity, and aggravation by daily activity. 2 out of those 4. And 1 out of these 2, nausea or vomiting, and photophobia and phonophobia, sensitivity to light and sound. So if you fulfill these criteria, you have migraine. And doctors can actually prescribe a medicine treating migraine. So pain sometimes do not require a visual abnormality. So what are the current possible objective measures? Sorry, it took a little time to get here, but most of the oral pathologists, this is where you try to see what is out there. First, the Loria's group published a paper in 2005, Trigeminal Small Fiber Sensory Neuropathy Causes Burning Mouth Syndrome. So in 2005, what they did was they took a sample of the patient's tongue from burning mouth syndrome and compared with a control group. What they found was a decreased density of epithelial nerve fiber endings. So QJ1, sorry, I think you know more about these stainings much better than I do. QJ1, PNP22, merge it and then compare with a control group and the burning mouth syndrome. So they saw, okay, so maybe a peripheral nerve ending is degenerating. We call small fiber neuropathy. This is a similar finding you can see in like a diabetic neuropathy. In diabetes, you can have retinal, nephral, and also a neuropathy from a glycated, advanced glycated end products, and it causes a degeneration of peripheral nerves. So there are evidence starting to build up histologically. We may be able to detect, and saying that there is another paper by, again, Dr. Yilmaz and Dr. Renton. It says that burning mouth syndrome as a trigeminal small fiber neuropathy, 2007, increased heat incapacitating receptor TRPV1, transient receptor potential V1, and nerve fibers correlates with pain score. So, the severity of nerve degeneration, they saw a correlation of the clinical symptom and histological findings. So how wonderful would that be to be able to actually see and point out, okay, you have something going on in your tongue. It is not going to come from just H&E stain, but a specific stain. If you can coordinate with orofacial pain or oral medicine specialists to build up more cases like this to see if you can find a similar finding, if we can combine that, we can add that to the diagnostic criteria of burning mouth syndrome. So these are the findings from the literature I just showed. Upregulated, downregulated neurofilaments, increased TRPV1, burning mouth syndrome, nerve growth factors. So, those are the things I would kill to see more and more come up in the literature, because it's just not enough out there. So please, the brightest mind from across the world, around the world, I want to see more research done in this area, especially from oral pathologists. Is there anything going on with a intraepithelial nerve fibers? Group from, I think, Europe, Jaaskleinen, has multiple literatures stating that a similar small fiber neuropathy and correlating with a quantitative sensory testing. So, those are the things I would like to see in the future. So I think my time is up, and here is my email address, my Facebook account. I do have a YouTube channel, so if you are interested in taking a look at the presentation, some are in Japanese, some are in English, but it's free, so take a look. Here is a QR code that you can scan. If you can pull up your phone and scan it, it will allow you to download the slides that I use for this presentation. If you have trouble downloading, then just take a photo of this slide, and I think you'll be able to try to read the QR code and reach the website. Well, thank you very much for your patience, and if there's any question, I'd be happy to answer. Thank you very much.
Okay, thank you, Dr. Ando. Is there any questions from the audience?